Pulmonary vein isolation is the process of electrically isolating the pulmonary veins from the left atrium so that tachycardia occurs in the pulmonary vein does not get conducted to the left atrium and cause atrial fibrillation. Pulmonary vein isolation is extensively used for management of paroxysmal atrial fibrillation and selected cases of persistent atrial fibrillation. Tachycardia foci in the pulmonary veins which initiate atrial fibrillation are mapped and ablated. It may be combined with other ablation lines for management of atrial fibrillation. PVI can be either a catheter procedure done in the electrophysiology laboratory or a surgical procedure done concomitantly with surgery for mitral valve disease. In the initial era of catheter-based PVI, ablation was carried out directly within the pulmonary veins. Some of these procedures were complicated by the development of pulmonary vein stenosis later. Later, it was found that ablation of the junction between the pulmonary vein and left atrium was more effective. Overall, more than 2/3 of patients get relief from recurrence of atrial fibrillation with PVI. Reablation may be useful in cases of recurrences. PVI is usually recommended for drug-refractory symptomatic paroxysmal atrial fibrillation. It may also be considered in case of intolerance or reluctance to pharmacotherapy. Success rates of PVI are much less in those with long-standing or persistent atrial fibrillation than in paroxysmal atrial fibrillation. Pulmonary vein ablation has been found to be superior to ablation of atrioventricular node with implantation of biventricular pacemaker in patients with heart failure. In that study, Khan, MN and colleagues randomly assigned those with drug-refractory symptomatic atrial fibrillation and ejection fraction of 40% or below with NYHA class 2 or 3 heart failure to either PVI or ablation of the atrioventricular node with biventricular pacing. There were about 40 patients in either group. Those who underwent PVI had a better symptomatic outcome, longer 6-minute walk time and higher ejection fraction. Complications noted in pulmonary vein isolation group were pulmonary vein stenosis in 2, pericardial effusion in 1 and pulmonary edema in another. One of the patients who underwent biventricular pacing had lead displacement while another had pneumothorax. Cryoballoon uses cryoballoon instead of the conventional radiofrequency catheter for pulmonary vein isolation. Dedicated catheters capable of achieving PVI with a single ablation lesion have been developed. A review in 2020 by Jason G. Andrade has discussed the role of cryoballoon ablation in the invasive management of atrial fibrillation.